Thanks everyone for joining our DBS Ambassador event this afternoon. I think we can go ahead and get started. This afternoon, we're going to hear from our BIDMC, neurology, and neurosurgery team, as well as some patient ambassadors who have undergone the surgical process. So during the presentations, if you have any questions, please put them in the chat. We'll have time for Q&A after the presentations. And this will also be recorded and posted to our YouTube channel. We'll email everyone when that's available. I think we'll get started first with Dr. Shabir Merchant. Dr. Merchant is a movement disorders neurologist with clinical and research expertise in invasive and non-invasive brain stimulation treatments for movement disorders. His clinical practice has a special focus on movement disorders, and he uses the latest technological advances for the diagnosis and treatment of several movement disorders, such as Parkinson's disease, tremors, dystonia, etc. I'm going to turn it over to him now.
Thanks, Hannah, for the introduction, and welcome everyone for this session today. I was just going through the attendance list. Several of my patients are here, so thanks for joining today, and hopefully we can answer several of your questions, which we sometimes go in more details when you see us in clinics for considering this therapy. But my job today is essentially give you a brief overview of what are the common indications in terms of, when to consider deep brain stimulation, who is a good candidate, what are the different things that we take into consideration for making that decision, for deciding what target we consider in an individual basis. Then we will also talk a little bit about the processes which we follow here at BI. In terms of our multidisciplinary team approach that we use here with Dr. Aronson, who's a neurosurgeon, and the other neurosurgeon being Dr. Alterman, as neurology as a team we have here, our colleagues in other specialties, speech therapists, neuropsychiatrists, and how we combine everyone's inputs and expertise into making the decision for you in terms of whether this is a good therapy for you. As far as the disclosures, I don't have any relevant disclosures for this talk or no conflicts related to what I'm going to speak today. This is just a brief overview of what it looks like. We just had Halloween recently, so, reminds us of Frankenstein. But let me tell you, none of this sticks out. Nothing is sticking out of your skull. Both Josh, Dr. Aronson, and Ron, Dr. Alterman, do a fantastic job with putting everything in place. Everything what you see here is inside your skull. And after the surgery is done, no one would even know that you have the stimulators implanted in you. And there is a small little battery pack which is implanted in your chest wall. I think you must be more familiar with cardiac implants in terms of the battery. So it's similar to that, and it's implanted in your chest wall under the skin. So this entire assembly of electrodes in your brain and the implants which go behind your ear, under your skin, and into the chest wall is all internalized, and there is nothing that sticks out, and you look as normal as you do, and there is nothing that really makes you feel different about yourself. Besides, of course, you have this brain stimulation in you. Factors for DBS success. Most important things is, we need to make sure the correct patients are selected for this, and the appropriate clinical window. I find it more and more, and I'm glad we are having this conversation with several of you who are early in your disease, that, it's not, a lot of the times, I mean, depending on the person, and unfortunately, this is the inverse correlation in between experience and how much you do in terms of when you get referred for this. Unfortunately, the idea about deep brain stimulation still is out there as if it's a last line therapy where all your medications are exhausted. You're put on a bunch of medications and they stop working, and you develop all these side effects, which are actually because of the medication, not part of your disease. And when all that stuff goes wrong, and then you are referred for deep brain stimulation, and then sometimes you develop a lot of complications from speech, you develop cognitive problems and your speech problems. And unfortunately, a lot of people who don't do this, a lot of physicians, clinicians also, who don't refer them appropriately at the correct time, that leads to not good outcomes, unfortunately, because your disease has progressed so long and you've developed all these complications. So it's important that you select the correct patients, but also the correct time in terms of when to do this surgery is important. The expectations need to be reasonable as to what do we want to do. We are treating motor symptoms. Some motor symptoms respond exceptionally well. Some, like gait problems, speech problems, cognitive issues, these are not the things that we expect these things, this therapy to lead to improvement. So it's important to have that dialogue, have clear expectations before you go into surgery, and be reasonable about it. That's kind of is most important, because this is a partnership we have, and we want to make sure that we don't tell you some things which are not expected to be getting better with this therapy. Careful programming, knowing what you're doing, understanding that you need to be having this therapy for several, hopefully in decades, in several of you. So we want to make sure that we do the optimal programming, but there is a nuance to it, and you should be, you should, I mean, all the physicians here, I can tell we all kind of do know what we do, but that's also very important that the programming has its own nuance. You need to know what you're doing and how you program these. And long-term follow-up is part of it, in terms of, not just monitoring your programming, also monitoring your medications, how to take you on, how do we manage your medications, how we reduce the pharmacotherapy load, and how slowly and how fast. It's always a learning curve. I've worked with several of you, and it's always kind of, it's a patient centric thing, and we try to make sure that we try to find a balance, but it's always a learning. So we are in partnership in this, in terms of the long-term follow-up with your feedback, how we monitor your medications and how we do the programming in you. uh, so realistic expectations, deep brain stimulation is not a cure. We can improve several of the motor symptoms, tremors, dyskinesia. These are fidgety movements that Parkinson's patients develop when you're on too high medications, and some people develop it sooner than later. This is not necessarily because of how long you're on medications. Yes, there is a component of how high the doses are, and everyone has its own. Some people develop it earlier, some later. Though that's dyskinesia, which is a complication from treatment from Parkinson's medications. Dystonias are abnormal involuntary muscle contractions. So you develop these postures, which are, again, sometimes they are related to being on the medication. Sometimes they can be a factor of wearing off of medications. Motor fluctuations, which means that you take the medication, you feel great. A few hours into it, before you due for your next dose, you again start to feel your Parkinson symptoms are coming back, and then you become slow, stiffer, your tremor comes back. So that's the motor fluctuation. That you take the medication, it takes sometimes a longer time in some people for it to affect. So essentially what happens is you spend several hours during the day where you are off, even though you are taking medications. Then you start to take more frequent dosing, and then that sometimes unfortunately leads to these dyskinesias, or these erratic fluctuations in your symptoms. And then when you take the medications, the dyskinesias are bothersome, that you're moving too much. And when your medication effects wear off, you're not able to move. So it gets you in this very difficult predicament, which deep brain stimulation is sometimes very helpful, to kind of alleviate that aspect. So that's a very good indication for deep brain stimulation. It does not slow down the progression of the disease, at least at this point. There is no data that we have that shows, but again, a good quality of life, not being tied to your alarm clock in terms of taking medications, being able to exercise, live your life, are all positive things that can improve your quality of life, if no disease progression. It takes time to achieve the results. When we get the surgeons, our surgeons are both excellent. I can vouch for both of them. And they both tried their best to put the leads in the right place, and we try to achieve the best results. But we sometimes don't get exactly what we all try to achieve excellence. But but again, after the leads are implanted, we start the programming process. We try to modify your medication, but it takes some time for us to eventually achieve. I give a timeline of about 6 to 8 months when we try to achieve, like with Parkinson's patients, when we arrive at a good level, that we kind of have achieved a good response, and things are more steady at that point. For Parkinson's disease patients, for most symptoms, the response is as good as your best levodopa response, like the best response that you have when you take your medications, in terms of your mobility, your rigidity, your tremor. Tremor being an exception, that in about 30% of Parkinson's patients, the medications do not are not helped, and that's another very good indication to do early treatment with deep brain stimulation for medication refractory tremor, instead of unnecessarily subjecting you to higher and higher doses of dopaminergic medications to try and get the response to tremor, that's a very good indication to do surgery early, because you essentially are left with no, or you don't have to take any medications once the tremor is taken care of. Because a lot of the time, most patients with a tremor dominant Parkinson's, they have very minimal mobility issues. It's just the tremor which just gets the better out of them, and the medications sometimes don't help in some subsection of those patients. Discontinuation of medication should not be the primary goal. But in most cases, especially with the subthalamic nucleus, we can reduce the amount of dependence on medications significantly. And I would say, like, to put it simply, think about Parkinson's disease or a neurological brain disorder. It's a chemical problem and it's also an electrical problem. So by giving you the dopamine supplements, we are trying to get the electrical problem to a certain extent under control. And when that is not under control is what the deep brain stimulation takes care of. And it restores this normal connection in the brain, so that your brain is allowing this additional ability for your brain to function normally. But again, your brain is deficient in dopamine, so we need to supplement that. But then we arrive at a good balance by combining these two therapies together to restore the chemical balance as well as the electrical imbalances in the brain by combining these two treatments. Parkinson's disease and DBS symptoms, which will most likely improve, are tremors, as I talked about, stiffness, or what we call rigidity in our doctor terms, slowness, which is what you experience, slowing, or bradykinesia is the term that we use, wearing off, that you take the medication before you're due for your next dose in a few hours, you're back to experiencing all your Parkinson's symptoms. And the last thing is the dyskinesias, or involuntary movements. Now, this can be are most likely happen at the peak doses, that when your medication effects are at its peak, you also notice that your involuntary movements are at its peak. So you're not able to maximize the benefit from the medications, because the dyskinesia are now affecting your ability to function and be able to move better. So now the symptoms which you don't expect to improve with DBS: freezing of gait, or some folks experience gait problems, balance problems with Parkinson's disease. That is not the primary indication. Of course, there is gait problems and balance problems which can be a factor of your Parkinson's disease, and which improve in your on-state, that when your medications are working. So if your medications are helping your gait, then the deep brain stimulation can help. But if the medications are not able to help your gait problems, it is unlikely that the deep brain stimulation. So it's not a realistic expectation to go into surgery if your primary goal is to improve your walking. Other things I talked about, a lot of times we talk about memory problems. Folks have hallucinations and illusions and things like that. Of course, now if the hallucinations are because you're requiring such high doses of medications, and by doing brain stimulation surgery, we are able to reduce the medication significantly, then you might have a benefit on your hallucinations, I would say that. But if that is not able to be achieved and your hallucinations are independent of the medication related side effects, then again, it's not a reasonable goal to do the surgery or pursue the surgery. Hypophonia or soft voice, that's another thing. Difficulty swallowing, those things are not necessarily improved, or that should not be the primary goal of pursuing surgery, especially if those things are not improved with your medication at the maximal and the best benefit you get with your Parkinson medications. Uh, other disorder besides Parkinson's disease, which we use this therapy, and I think it is the best therapy out there, is for tremor, or essential tremor, which we call it. These are action tremors. So these are the tremors which you have when you move your hands, or you're trying to drink or feed, write. Those are the tremors that are exceptionally responsive. I will tell you, a lot of, unfortunately, several of folks who experience these tremors are on the elderly side. We can use medications. There is evidence that these medications can help the tremors or alleviate it. But if the tremor becomes severe or moderate to severe, that you're finding it very hard to feed yourself and do those things, these medications, I have honestly, be very honest, I haven't seen that the medications really help. And I am from the school which believes that I don't believe in unnecessarily exposing folks to more and more medications which have side effects. So all the medications which we use for tremor disorders have sedation, increased loss of awareness, dizziness, all the things which are very common are very common side effects with these medications, especially with higher and higher doses. We try to use these medications, of course, as first line and try and see if we can get a significant improvements. But I've seen that it helps in about half the patients, and half the patients, the response to even what is claimed to be the first line medications is not very good. Now, when you're considering treatment for tremor, things which are not very responsive, voice tremors, I've seen they respond when you have a bilateral implantation. There is some degree of improvement in voice tremors. The head tremor also improves with bilateral implants to a certain degree. But if the primary reason why you want to get there, but the main reason why you should be operated for or get surgery for tremor is for limb tremors, for tremors which are disabling you from not being able to eat, not being able to drink, feed yourself, wear your button yourself and do any activities. So though that should be the primary reason, these are all the other things which the tremor can sometimes affect, but these are not the indication for pursuing DBS for tremor disorders. Moving on, about dystonia is the other problem. Now, dystonia is a couple of different things. It can happen as an independent problem. There are genetic forms of dystonias, and the best evidence is for kids who develop these DYT1 dystonias. That's the best evidence for the efficacy of deep brain stimulation. And also the best evidence is if you're operated early on, if you are an adult who has generalized dystonia of childhood onset of genetic form, and if you are treated into adulthood, the effects and the benefits are not as dramatic or as good as if you're treated early on as a child or an adolescent with this dystonia. Dystonias are also part of Parkinson's disease, and sometimes by doing this deep brain stimulation, the dystonia, which is otherwise not responsive to medications and at the best doses of medications, we see patients respond very well to these treatments for deep brain stimulation for Parkinson's disease as well. Another type of dystonia where this really helps is medication induced. So there are certain medications, especially of the antipsychotic class, where folks develop what this type of dystonia called tardive dystonias. The evidence there is good. So if these dystonias are not helped by taking you off the antipsychotics and putting you on medications, which sometimes helps these drug-induced dystonias, that's where we have found good response. Dr. Aronson will share his experience about his experience with dystonias and his patients. But those are the general literature out there and what we see in clinical experience. Poor candidates for dystonias are certain types of secondary dystonias. For instance, if you have a stroke in certain parts of the brains and you develop these abnormal involuntary contractions. So now you can imagine if you have dystonias from brain damage, from either strokes or any other vascular lesions or any trauma, and those regions of the brain where you do the deep brain stimulation are already damaged or the tissue is already lost, you won't be able to achieve much of a benefit by putting an electrode there and try to stimulate those regions, right? So secondary dystonias from structural etiologies, but also sometimes some metabolic disturbances which cause the entire brain to be abnormal. It's hard to get a good benefit in those type of dystonias. Now, the approach for deep brain stimulation is multidisciplinary. It includes me as a movement disorder neurologist. We have the expertise of surgeons, Dr. Aronson, Dr. Alterman. We have a neuropsychologist who kind of go over an entire battery of cognitive tests to understand your memory and thinking. Because sometimes in Parkinson's disease patients, if you have a lot of cognitive impairment, that means that you have memory problems or early or signs of dementia. We have noted that after doing deep brain stimulation, there is sometimes a progression of that and worsening of that. So it's important to understand the baseline cognitive problems or memory. How are you in terms of your memory and thinking before you pursue, because that leads to realistic expectations and knowing what your problems are before you go into the surgery. Again, as I said, that is not a good indication for pursuing surgery. The next thing is speech therapists. Sometimes folks have a lot of problems with speech. They have slowness of speech. So that's something which we pursue here. It's mentioned as optional because a lot of programs don't offer it. In our program, we have made it especially for Parkinson's disease patients. We want them to undergo speech therapy and have our speech pathologists figure out if there is anything that we need to be concerned about in terms of your speech issues, and if that's a big problem that we might experience post surgery. Our social workers are there to hold your hand, understand, go through, all these issues. You have a lot of after surgery, there are needs that sometimes are required, nursing services and things like that. So our social workers are very good in terms of helping out with several of those things. And certain cases, we recruit psychiatrists if there are a lot of behavioral issues, a lot of major depression problems, a lot of issues with hallucinations and delusions. So in those cases, it's important to stabilize your mental health issues, and we seek psychiatry input if that is a reasonable thing that we can achieve before we pursue surgery. Uh, Next thing is the first programming visit. Again, the first programming visit happens after the brain stimulation surgery, and I won't go into that. Dr. Aronson is going to speak about the details of the surgical procedure. The first visit is about 3 to 5 weeks after the implantation, after the surgical leads electrodes are placed. The first visit takes about an hour, hour and a half, depending on which contacts and are stimulated, and how many, if you're operating 2 electrodes versus 1 electrode. For Parkinson's disease, the first visit, we like to bring you in a medication off state, which means that you take the dose the night before and you don't take your morning dose on the day when you come into the surgery. It is just good for us to know what is, because we want to know the maximal benefit which you got in your medication on state. Are we able to achieve that with the brain stimulation? And then we try to then introduce the medication. So I usually don't, after the first visit, when I have known that what's your medication off state benefit with just the deep brain stimulation, for the subsequent visits, I like you to come in your medication on state to know how you are doing, combining the effects of medications and deep brain stimulation. So that's something which I do. First visit, I also look at the incision sites, look at the electrodes, how they are. We also systematically go through each of the individual electrode sites to know how are they in terms of the anatomical location, and to gauge which will be the best contact to stimulate and help with your therapy for brain stimulation. Things which we do is amplitude. So this is the total current intensity that we use for stimulation, the pulse width. So there are different electrode configurations of how the electrical pulse is given, and the rate, which is the number of pulses we are given per second, or the frequency of stimulation. Those are 3 parameters which we monitor. Now with the added complexities of programming, we have all this directionality and things like that which we use and help to optimize the therapy for you. The therapy initially we have set so that the first few visits are on a monthly basis. We understand several of you travel from distances, and we want to make things easy for you. But after the first 6 months, usually things are more streamlined, and your visit frequency is equal to what you usually do in terms of follow up for your regular Parkinson's disease visits. So between 3 months to 4 months to 6 months, and I actually allow that to be your decision. A lot of the times it's a partnership, and we like to consider the trouble which you have to take to come in, especially if you're coming in from distances. What we do is, I just wanted to have this picture, this cartoon here, to talk about some of the newer technologies in terms of how with these directionality we are able to provide more refined way in which you could do this brain stimulation. So just give you an example. For instance, if you look at my pointer here, if you were to stimulate an electrode contact, for instance, if we take an example that if we stimulate this one contact here, it would create a sphere of charge around the brain. But now if you, instead of having this circular contact, if we break it down into a thirds, what you could do is you could further refine the stimulation by changing the instead of having a sphere of charge, you can modulate the field so that now you can stimulate what you call is the sweet spot, which gives you the best benefit with the stimulation. But at the same time, avoid this sour spot, because you can imagine there are so many different structures and so many different pathways which are going around the electrode, that when you can stimulate certain parts of the brain and cause bad effects in you, like contractions, sensory stimulation, which are discomforting. You can cause symptoms of lightheadedness and things like that. So we want to avoid those. So having this refined way of stimulation allows us to stimulate you in the regions which give you the best benefits, and at the same time avoid side effects from the stimulation. I found this new, to just to give you a range of things which are available right now and what's coming. These are all the different types of different stimulation ways in which we can do. So if you can imagine, these are all the different new devices. We have multiple different contacts. Some of them are in the pipeline, which will allow us to kind of modulate the field in a different way. So for instance, if you were to see, if you have a spherical contact like this one, you are having a spherical field. But if you have this directionality, you can model the field to provide you the best benefit and avoid any side effects from the stimulation. So that's that. These are some of the examples of the battery. There are several more which have come in since we kind of came in with this presentation. These are rechargeable batteries. They are by default, the rechargeable batteries now are very slim and tiny, and you don't even, it hides very well in the chest. You don't even know if it is there. Compared before, it used to be bigger batteries. These are the three companies, the Abbott system, the Boston Scientific system, and the Medtronic system. These are three different batteries. These are the rechargeable batteries. There are also non-rechargeable batteries, which are equally tiny, and the technology has evolved fantastically. And all these companies are doing a very good job in terms of making things more and more sleek and adaptable for you. I just made this slide today, just thinking about reflecting on the evolution of DBS technology and what could be coming in the future. I mean, for the longest time, I think me and Josh both kind of have been here enough to kind of know about this. And it actually just seems like yesterday when we were training that, we used to do constant voltage stimulation. And over the last 8 or less than 10 years, there has been a tremendous increase in technology, and the field is going is a good pace. But I think I would just summarize that, we used to stimulate using constant voltage, which would mean that we set the stimulation at a certain voltage and it would deliver a current based on the changes in the tissue of the brain. Now, with the constant current stimulation, the systems are able to adapt and deliver the same current, even if the brain environment changes or the resistance of the system, which is delivering the stimulation, changes. Then more recently, about not even 5 or 6 years back, we came with the era of segmental stimulation, which I showed you how you can modulate the field to provide more precise stimulation. And now with some companies, the Boston device, for instance, has this MICC stimulation, which allows you to even provide even more refined stimulation by treating each of those individual electrodes as an independent entity and modulate the field. Some new technologies and some more data coming out from the Medtronic system about this, what you call is closed loop stimulation. Whereas what the advantage of that system is that the system is able to, the electrodes which are implanted, which are using for stimulation, they're also able to record certain brainwave activities. And there was some evidence that, certain brainwave frequencies are related to symptoms in Parkinson's disease. And so what the system is doing when it finds that there is an increase in those brainwave activities, it stimulates the brain. And when those brainwave activities are low, it doesn't stimulate it as much. So that is called adaptive stimulation. There are several unanswered questions, and it is not approved and not available right now. There is some elements of it are, and they are coming up with there are some studies and some data out there, but there are several unanswered questions about that technology right now. Another way to stimulate is use image guided. So, you get your MRIs and your CT scans, and after the surgeon puts the electrode, we can repeat those scans and we can put your brain structures. And now we can look at the electrode in relation to the brain structures, and based on how we have learned about what structures, stimulating what structures of the brain provides the best benefit. So now this will be an automated way in which you can put the scan on, and based on you can select the regions of the brain where you want to stimulate and select the brain regions where you don't want to stimulate, and the system will develop automatically a stimulation sort of a guide. That's kind of again, several unanswered questions. We are yet to trial it, but this is newer devices which are coming out and newer technologies which are being developed, which are going to focus on image guided programming as well. And the last thing is the telehealth or the remote programming. Again, it's a struggle because a lot of folks have patients coming all the way up from Maine, from Western Mass, adjoining states, because for many different reasons. And again, it's a kind of a struggle sometimes to kind of do this programming. So this is an advantage with all of these companies are looking into in terms of being able to provide this stimulation remotely, that you are in the comforts of your home and we can program into your device and provide this stimulation remotely, instead of you having to come in for so many hours and travel all the way here. So that's some of the things which are available with some of the devices. The Abbott company has this technology available. The struggle has been, the whole point of it was for me to be able to help someone up in Maine or in other states which are adjoining, but the insurance companies are now making it prohibitive by not allowing us to do telehealth for patients outside of the state. So those are the regulations and things which are in the works, which are not making this practical or take advantage of this. But some of these things, and the other companies are also, as I understand, speaking with their tech R&D and staff, that they are also working into making this a reality, that all the devices will eventually have some way in which we could do this remote programming. Um, and lastly, these are some of the resources about deep brain stimulation. I always like you to refer to the more credible ones. Michael J. Fox Foundation, the Parkinson's Foundation, these are credible places where you can find your correct resources. The Essential Tremor organization is another place to learn more about the deep brain stimulation. The Dystonia Foundation, the Dystonia Medical Research Foundation, DMRF has its own website and has patients who provide have support groups, as well as the experience and leaders and folks who are researching this, and are clinicians who do these treatments. You're able to get their inputs about it, and of course you can always reach out to us, and if there are any questions, and we have our wonderful ambassadors who always make time for this and help patients ask questions directly from them. And with that, I would like to thank you. I understand the Q&A session will happen for both me and Dr. Aronson after his talk. So I'll wait and I'll read any questions and I'll try to answer it in the interim on the chat.
Great. Thank you, Dr. Merchant. Now we're going to hear from Dr. Josh Aronson, who serves as a functional neurosurgeon and director of epilepsy surgery here at BIDMC and as faculty at Harvard Medical School. He received his undergraduate degree from MIT and his medical degree from Harvard Medical School, and his practice is focused on DBS and epilepsy surgery. He also directs a federally funded research lab investigating how neurostimulation changes brain networks and focuses on development of next generation neuromodulation technologies. I will turn it over to you, Dr. Aronson.
Thanks, Hannah, for the introduction. Thanks, Dr. Merchant, for that excellent overview of how we use DBS in movement disorders. I'm going to try to go over a little bit about the surgery. So, as mentioned, I trained just down the road at Mass General, and then I was up at Dartmouth in New Hampshire in practice leading their movement disorder program for about 6.5 years, and joined Beth Israel just under 2 years ago. So it's been wonderful getting to know the Beth Israel community. And I'm going to talk a little bit about deep brain stimulation and how the surgery actually has changed quite a bit over the years in ways that make it, I think, safer and more effective. I've given my email address here and our phone number, and I'm happy to answer any questions over email as well. So let's see if we can get to the next slide. Here we go. So I do have a few disclosures, mainly in research support, which two of which are relevant here for Medtronic and for Abbott. The Medtronic one is about a different device that is used for epilepsy, and Abbott is about using deep brain stimulation for depression, which is a new clinical trial that is about to start, but not directly relevant to movement disorders. So when we think about surgical options for Parkinson's disease and essential tremor and dystonia as well, we have lesion surgery, which is a destruction of an area of the brain, and deep brain stimulation. And those lesion surgeries were really, all we had to offer from, the 1950s until the 1990s. And these were either thalamotomies or pallidotomies, named after different areas of the brain that we were destroying, using either heat or radiation, or in today's day and age, perhaps with a focused ultrasound. And deep brain stimulation, came about in the 1990s as an alternative. And the advantage of deep brain stimulation is, compared to the lesion surgeries, which were destructive, this is a fully implanted, non-destructive therapy. and it can be done on both sides of the brain, unlike lesion surgeries, and tuned. The device itself has three components. It has wires that we call electrodes that go into the brain, and then extension wires along the neck. And the extension wires are very stretchy and elastic. So when you move your head around, they stretch along with you. And then a battery called a battery in the chest, which is really the battery in the brains of the device. And then there's another component, which is the patient programmer. So you get a lot of ownership over your device. And if you're comfortable doing it, we teach you how to do this. You can change your DBS settings and sort of act as your own DBS programmer within some safety parameters that we set. So there's these components to the device. And it seems like sometimes when you first hear about it, pretty new technology, but it's a pretty busy slide. But we know that the brain is electric, and we knew that back into the 1930s. And using electrical stimulation happened in the even 50s to 70s. Importantly for DBS, this really started in the late 80s, and US approval came in the late 90s. And so we have now got, nearly 30 years of experience with deep brain stimulation. And we found that, with time, we've gained more experience with using DBS earlier in the disease course for Parkinson's disease, experience with doing the surgery asleep, which I'll touch on a little more. And then, as Dr. Merchant mentioned, segmented leads and the ability to not only put electricity into the brain, but also record from the brain. And again, something I'll come back to. In 2020, just in time for the pandemic, Abbott came out with remote programming, and they remain the only company that offers that ability to do remote programming. And then expected probably early next year is this idea of closed loop stimulation, which again, we'll discuss a little more. Now, as we talked about the ablative surgeries, for the most part, we're limited to unilateral treatment, meaning we can only treat one side of the brain. And we knew that these surgeries, especially if we tried to do them on both sides of the brain, had a lot of complications, speech complications, psychiatric complications. And so, this is, data that came out in the 90s showing that clearly DBS was a better option. And so when we think about DBS and which symptoms respond, again, going over a little bit what Dr. Merchant had mentioned, tremor, resting tremor in particular for Parkinson's disease, hypophonia, micrographia, and rigidity, all, the low voice, small writing, stiffness, rigidity. These are all part of the motor symptoms of Parkinson's disease, some of which are going to respond better than others. The shuffling gait and balance difficulty, unfortunately, responding a little less well. In addition to the motor symptoms of Parkinson's disease, there are non-motor symptoms, mood issues, cognitive issues, particularly late in the disease course, sleep problems, which I saw was asked about in the chat, and then autonomic dysfunction, meaning those systems that we don't have to think about, that our body just does, that also can be going awry in Parkinson's disease. Typically, patients with Parkinson's disease, about 5 years after they start therapy, usually with Sinemet, start experiencing sometimes dyskinesias, which can be either at the peak dose of the medication or even at the low dose of medication, on-off fluctuations. So, the medications are helping, but rapidly wear off. And, it used to be 4 or 5 hours of good on time. Now it's only maybe an hour. And coming along with this is reduced mobility, trouble with walking, more tremor, more rigidity, more impact on daily life. And then we see some carbidopa-levodopa resistance. So the Sinemet just is not helping as much as it did. And so we can implant a deep brain stimulator device, and we would expect certain symptoms to really respond quite nicely. And those you can see on the left side of the panel are the symptoms that we expect to really improve quite significantly. Tremor, perhaps even more so than tremor response to medication. We can see an even greater response to DBS. Also, rigidity, stiffness, slow movements, the dyskinesias, dystonia, and the motor fluctuations. More resistant, unfortunately, some of the speech issues, balance issues, and freezing of gait. Gait is a particularly difficult problem. Sometimes gait is really related to rigidity, and in those cases, we really do see some significant benefit. What's not improved, cognitive issues, as we mentioned, dementia, psychosis, atypical Parkinsonism. So again, making sure that we have the right diagnosis. So again, we'll get to that in just a second. We have two targets in the brain for deep brain stimulator placement, and there's certain factors that lead us to favor one versus another. So the subthalamic nucleus is particularly good in patients where there's a severe tremor that we're trying to address or severe fluctuations, where one of our goals might be medication reduction. So for someone who, for example, has a lot of dyskinesias, a lot of unwanted movements related to high doses of medications, getting someone on a lower dose of medication might make a very significant difference in their dyskinesias, and so we might favor subthalamic nucleus. The globus pallidus also a good target, particularly in cases where there's a lot of dystonia or foot cramping, severe dyskinesias that especially are not related to medications. Sometimes folks with more gait problems, or if there's a concern for some cognitive issues, sometimes we favor the globus pallidus interna. We used to have discussions at our meetings about which is the better target. I think we all recognize now that these are both good targets, but should be tailored perhaps to the right patient. So what happens at the first appointment with neurosurgery? And I have many patients who come and see me, and the first thing they say is, I don't think I want surgery, but I want to learn about it, which is completely, fine and expected, and I think is exactly what you should be doing. It's hard to know when a surgery might be right for you without knowing the details of the surgery. So I have many, many patients who come in, learn about the surgery, and then may not be ready for surgery for several years. But I think learning about it early can help you understand, what it is and when it might be ready as an option for you. So in the first meeting, we'll discuss your symptoms, how they've progressed, what they were initially, what you're currently managed on for medications, and what your goals are. I've had patients where they have a significant, especially in essential tremor, I had a patient who had a very significant voice tremor, which he had had for most of his life. And he was CEO of a corporation, gave speeches to his employees, and the voice tremor never bothered him. But over the years, it had started to become more of an arm tremor, and that's really what he cared about, right? And so those are cases where, again, understanding your goals from surgery can help us think about, is surgery right for you? And how does that actually maybe change our surgery? What other medical problems do you have? Things that might need to be optimized or managed before we go ahead with surgery, and understanding cognitive and psychiatric symptoms. So we'll have, a pretty long discussion of about an hour in the clinic. And then if we're thinking about moving ahead with surgery, there's two evaluations that everybody, especially with Parkinson's disease, gets. This is not necessary for tremor. The first is on-off testing or off-on testing, and this is performed by your neurologist. So typically you would arrive in an off state, meaning you don't take your medications, and your motor symptoms are scored. You take your medications and they repeat the evaluation, and again, scoring your responsiveness to medications. And this gives us a sense for what symptoms would respond to DBS and confirm your diagnosis of idiopathic Parkinson's disease, and probably not, one of these Parkinson's plus or atypical syndromes. And the neuropsychological testing performed by neuropsychologists. And this is a set of cognitive and psychiatric tests to identify factors that might limit your response to DBS, and also pick up things that maybe would suggest an atypical Parkinson's. And I think, for neuropsychological testing, we're very rarely surprised. I think a lot of folks feel pretty anxious about getting a test of their neuropsychological function, like it's like an SAT. It's meant to be, a challenging test, but I think the great thing about it is the report that's generated sort of says, what are your strengths, what are your weaknesses, and I think, all of us should probably get these done every few years and understand, how we best can learn. But this is a pretty standard metric that we get, again, on every Parkinson's patient. So often the question comes up, who's the best candidate? Who really should have this surgery? And I think the best candidate is someone with a clear Parkinson's disease diagnosis. So not an atypical Parkinson's disease case, not multi-system atrophy. And that's something that I think your neurologist can help you figure out. And if you've had a good response to carbidopa levodopa, having a good response to Sinemet predicts a good response to DBS. And we talked about how tremor might respond better, but again, it's the patients who have a good response, even if that response is not as good as it used to be, is not as long lasting as it used to be. If it's only lasting an hour and it used to last longer. But again, it's that best response. And what we'll try to do with DBS is extend that good on time. And then having good cognitive function, which doesn't mean you kind of notice that, it's taking you a little longer to get dressed in the morning or things like that, but still having a good cognitive function can help. Now, as far as the surgery itself, so we used to do these surgeries with folks awake during surgery, and it generates, some very nice YouTube videos of folks, playing the violin during surgery. Um, but that was sort of the standard for a lot of the history of DBS, and that's actually how I trained is with awake DBS surgery. And the reality is that we don't really need to do surgery awake anymore. And I saw that came up in the chat, and I feel pretty strongly about that. And I say that as someone who loved doing awake surgery, and I thought this was really the way to do DBS surgery. Had a lot of confirmation in surgery, but for the last, I would say, about 5 years now, I've done all of my DBS surgery asleep, and we'll go over that in a little bit. Now, there is robotic surgery, and a lot of folks get excited about robots, myself included. So this was a robot that we were using for awake surgery to try to make awake surgery more comfortable. But if someone's talking about robotic surgery, it doesn't necessarily mean it's going to be a very different experience if you're awake. So I think robotics was a good step to making it more comfortable. But again, I think we don't need folks awake. And so a sleep DBS is DBS under general anesthesia. And the reason why we can do that, in 2024, and we could not do that in 1997 when DBS first came out, is to me these advanced MRI sequences, which let us do what we call direct targeting. Indirect is, off of an atlas, sort of standard coordinates. We measure this far off and this far up and this far over, and we rely on you being awake to taper, that or refine it a little more. Now, with advanced MRI sequences, I think we can accurately target in a patient-specific way. So that's using your MRI, looking at your imaging and picking the best spot for you based on your own imaging. And we can use real-time imaging in the operating room, whether it's CT scanning or MRI scanning, to make sure that we're getting the accuracy that we need. Because, being 2 millimeters away is like directing someone, into Boston and telling them to find Fenway Park. You're never going to get there. You need exact directions, right? So 2 millimeters is, Copley Square, not Fenway Park. So what this also lets us do is, typically we would spread DBS into two surgeries, electrodes in the brain being one, and then a week later, the extensions down the neck and the battery in the chest as two. Now we can combine it into one stage and, make it more convenient for patients. And typically you would spend one night in the hospital total. Now to go over the targeting. So if we had standard MRI, which is basically what we had in 1997, you can see here, this is a DBS trajectory and this is a target, and it's all shades of gray. And I couldn't tell you that, where that orange spot is, if you can see it here, is the target. But, we can zoom in. We really can't see, on a standard MRI, what our target should be. What we can do now, though, is we have, this on the left side here, our standard imaging, which we cannot see our target. But on the right side, there's a sequence called QSM. This is an advanced MRI sequence. And now you can see outlined in this brighter light color in white is our target, is our subthalamic nucleus. So now we can sort of see our target on a patient's own MRI. And I think that's made a huge difference and lets us do DBS surgery asleep. And again, there's another image where we can really see, outline in gray and white here, exactly where we want to aim in ways we, again, didn't have years ago. Now, for essential tremor, we would have this, again, standard targeting. We'd measure off of a point in someone's brain and say, that's our target. And, these are our various drawings of, where we should target. And this goes back to, again, the 1990s, where we had, only limited patient-specific imaging. Now, the important point, again, here is the accuracy has to be extremely clear to within 2 millimeters, or else we'll give patients side effects and not accurately help them with their tremor. So we still can't see, even on newer MRI sequences, this target for essential tremor called the VIM. But what we can see is that there's a white matter tract, one of the wires of the brain, called the DRT, has this long name, the dentato-rubrothalamic tract. And that passes through this area where we want to place the DBS electrode. And so we can use patients' own imaging to identify where we want to hit, which is this pink color, and also areas we might want to avoid because they'll cause side effects. And that's in blue and in green. So I can combine all of this and place my DBS so that it's buried in these, pink spaghetti, which is our target, and we can avoid the blue and the green spaghetti, which is going to cause side effects. So again, this is technology that didn't exist in the 1990s and exists today. So we can now do this surgery safely with folks asleep. And so, this is, I think, still slowly kind of getting out into the neurosurgery community. And I'm writing up my own experience of doing, a whole lot of folks this way and seeing good results. And so that brings up the question of, what are our results with the sleep surgery? And this is a meta-analysis. So they looked at a whole lot of studies. And the reality is that we were getting good results with awake surgery. It's not that we weren't getting good results. It's that most patients would rather not be awake while someone's drilling a hole in their head for, obvious reasons. So we are getting as good a result with patients asleep, right? So our gold standard was awake, and now we would say there's not a reason why someone has to be awake for their surgery when we're seeing equivalent results, equivalent good results. And lastly, I wanted to touch on this idea of closed loop stimulation. So this is something that currently only Medtronic has. And so their Percept device that came out a few years ago had this ability to record signals from the brain. And we use this in programming, but when we say closed loop, we mean a device that will look at brain signals and change its programming in response to that. And for the few years that we've had this Percept device, Dr. Merchant was closing that loop, looking at these signals and then changing the programming. But as awesome as he is at programming, he's not, with you 24 hours a day, 7 days a week, changing the programming in real time. But the device, in theory, could. So there was a trial that just finished called the ADAPT PD trial. The results are not published yet, but they've shown some of the results at different conferences. And so the device can be programmed so that when it passes a threshold, just like the thermostat in your house, if this signal that corresponds to symptoms goes up, then stimulation can go up and push that signal down, and then the DBS can go down. Now, we also know that there's an oversuppression. So if the signal's too far down, then DBS can, lay off a little bit and kind of keep that signal in a good range. And so how this is done is we take a look at the signals that are recorded from the device and we pick a frequency. So here it's 16.6 hertz in this beta range. We say, okay, well, that corresponds to, let's say, a certain symptom that we want to target. And then we can have this sort of threshold. And so you can either have a single threshold, which is kind of what your thermostat does, it goes on or off. Or if you have central air and a heating system all connected, right? This is a dual threshold. So if it goes below, it goes above, and it keeps you kind of in this middle range. And it turns out, if you use this dual thresholding, it improves the on time versus standard DBS by an additional 1.4 hours. So this seems like a pretty good idea. And the nice thing is, for folks who have the older Medtronic devices, this is all living in the brains of the device, so all in that battery. So folks who have older devices, if they get upgraded to the new battery, they can also take advantage of this new technology. And so I think this is one of the biggest changes, that and the rechargeable. So, I tend to, see the companies as all offering something, kind of a little bit different. I think Medtronic offers, this ability to record activity, which is interesting and I think very promising. Also offers the multi-independent current control. And then Abbott offers a unique ability to do the remote programming, which for folks who live kind of far away, I think is an advantage. Boston, I think, right now doesn't quite have anything particularly unique to them, but also makes a good device. So in conclusion, I would say, DBS surgery, it has improved, it's safer and easier. I think the when and whether to undergo DBS is a very personal decision, really dependent on your goals, your symptoms. So I think there's only one way to really assess that, and that's to talk to your neurologist and to meet with a neurosurgeon. And honestly, if you don't like that neurosurgeon, meet with
Yeah.
a second neurosurgeon. And then I would say awake and asleep surgery, they both remain options, but I would say, for me, I think given that asleep surgery results are on par with awake, I, at this point, never really do awake surgery at this point. And that was really driven by patient preference. And again, that's because of this advanced imaging, which make that direct targeting, targeting based on your own anatomy possible. And then I think, the biggest thing I'm looking forward to in the next, I would say, few years is this closed loop programming, which again seems promising. We'll have to see how it works, in the real world, once we get it unlocked by the FDA, probably at the beginning of this year or 2025. And so I will stop there. And again, please feel free to reach out with an appointment or just send me an email with any questions, and we can um, take any questions.
Think I want to make sure that me and Dr. Aronson are able to tell you the same thing. And I think I agree with most of the things he said. But again, I just like to kind of tell you as a person who has his own experience with this programming. And the reason when I put in my chat is there is a lot to learn about this programming. This adaptive DBS programming, that data which Dr. Aronson is referring to, was presented 2 years back at a conference, and it's still not very out there. Okay, so I just want to tell you, most patients, when I see them, especially who are tremor dominant patients, I don't see this beta peak. This beta peak keeps varying, so there's not good consistent. So I mean, it looks great when it works, but if it doesn't work, there is no reason for me to do all this adaptive programming, and it works just fine. So I'm just going to make sure that there is nothing, in my opinion, that this technology is there. It's just saying that all the devices are equivalent, and I think the closed loop programming is might be helpful in the future when the technology is improved. As it stands right now, and even if the approval is met, I don't really think that you can find a consistent peak. What the peak is recorded, where it is recorded, there is no good data to support that it's actually coming from the region where they claim it's to be. So there is some questions about it. I just want to like to make sure that sometimes these things are very simply told to patients, but there is not much of substance to it. That at this point there is no one who can say that you're going to have an automatic robot who's going to program you better than a clinician. So I think find a good neurosurgeon like Dr. Aronson, find a good programmer who knows what they're doing. That's going to last you longer. And there are all this AI ML is a big word these days, and people try to think that this is true, but unfortunately, it is not. So that's why I'm saying a lot of unanswered questions at this point. And about that, so I would say that precise programming using the right regions of the brain stimulation is more important than anything. And I don't think anything is more important and more advantageous than that as it stands right now. That's my opinion. I think Dr. Aronson has experience, so I don't really think that adaptive DBS is as great as an advancement right now. Again, I have no conflicts of interest, and I don't have any player. I like to do things based on the patient's preference, but I like to make sure that you have the correct ideas about why are you getting a device and whatnot. The implant from 10 years back, I don't think that is compatible with the new for the adaptive programming. Is that correct? Or because the directional ones which they came out are, but if his implants are more than 10 years back, I'm not sure if you can change that.
Yeah.
Correct? Or
You
what your thought?
you can still use the Percept
Okay.
device. It is still compatible.
Okay.
You don't have the directionality benefit, but most patients, although there is this directionality to kind of steer the electricity one way or the other, most patients are still programmed to a full ring. So it just means that we have only four choices in your case instead of eight, but absolutely it is still compatible. It's actually a little bit of a surprise, I'll say, to Medtronic when they realized that actually the recordings they were getting from the old wires were actually better than they expected. So
Hmm.
it was a happy coincidence, or a circumstance that they're good enough to use for recording. As Dr. Merchant mentioned, not everybody has a perfect peak to use.
Mhm.
And that's something that, we may learn why that is. It may be placement. It may be, certain patients, have some feature of their Parkinson's. I mean, I think we have these tools now. We never had them before. So we'll have to see, as a field, what we learn collectively once this is not, a small trial with a few hundred patients, but our collective, national and international experience.
I don't see any other questions in the chat. So I'm going to stop the recorded portion now.